Hello, everybody, and welcome to part 2 of our interview with Sorcha Martin. All right, so last time we talked a lot about the conversation, talked a lot about some of the barriers to like access for patients, and just generally like how important it is to have that patient-centered care approach, particularly in the initial part of a patient's care in PT.
Yeah.
Now, moving past that initial part, what does that look like? Okay, once you've established, particularly if a patient has a nociplastic sort of like type of pain.
Yep.
What's your approach in designing interventions long term?
Yeah, that's a great question. I think the first question I ask is, what is their response to exercise? Right. So if there's somebody who feels better with exercise, fabulous.
Yeah.
Then I know that I can take a graded exercise approach combined with education, manual therapy as it's needed to help decrease some of that pain experience for them,
Right.
and build a treatment plan around whatever their particular goals are.
100%.
That's sort of the ideal case. If they don't have a positive response to exercise, if there's somebody for whom exercise makes them feel worse, then I have to start to think about, is this somebody I need to be doing things like graded motor imagery, mirror therapy, laterality training, sensory training. So that becomes a different animal.
Yeah.
So I guess my first recommendation for either newer clinicians or students would be start with, what is their response to exercise? We talk a lot about global exercise as a pain modulator, and for many people it is,
Right.
which is great. So start with that. How do you feel if you do 10 minutes of exercise? Enough to get your heart rate up? Is your pain better, worse, or the same?
Right.
Your expectation would be that their pain would be better. Great. Then I continue to use exercise. If their pain is worse, then you got to start to think about, okay, are there some premotor things I need to be doing and reevaluate?
Right.
But that at least gives you a decision point where you're like, because you don't know that necessarily. And it might be hard for your patient to tell you that information. In your exam, it's one of the questions I ask. Do you generally feel better if you go for a walk? And it can sometimes be hard to know. Like, I don't know. Walking is painful. Well, what about the bike? That might be better, right? So the difference between what is the cardiac response to pain and what is doing that particular task is challenging, because it can be hard to tease out, is it an inverse response to exercise, or is it that particular task is a pain driver for them? So I try and pick something that's not associated with the thing that I know makes them feel worse. So whether it's the bike, the elliptical, a walk, whatever it might be, to just try and get the heart rate up and see, does that make them feel better?
I think that's like an interesting thing too, because imagine having that conversation with the patient. They're like, so walking hurts, but maybe the bike will feel better. It's like, but I'm still moving.
Right.
Isn't bike harder than walking? Like,
Right.
why would that make me feel better? Yeah. Do you get that? Like, do you kind of get that pushback?
Yeah. I think, but people are fearful of making things worse, appropriately so, because nothing has made them feel better. And oftentimes their nervous system is becoming more sensitive. So they objectively feel worse. So the idea of doing more things is overwhelming and can be fearful.
Yeah.
So I think having a good rapport and getting that good education down where, look, it's safe to do this. And I use words like that all the time. Like, this is, this might be sore, but it's safe to do. That's a common phrase you'll hear if you're treating next to me in the clinic. And I ask the patient, how do you feel about trying that?
Yeah.
This is what I think we should do. This is the information it will give me. How do you feel about trying that? And sometimes like, well, and I'll say, we can stop at any time. Like, if you start, and if 2 minutes in, you feel worse, I have the information I need. We don't need to do 10 minutes just to make that a magic number.
Right.
But I usually ask for 10 minutes of cardio and then decide from there.
Yeah. I think there's also a great thing too, is like even just a general approach, even outside of just the chronic pain world, where like you have a patient do an exercise, like, oh, that didn't feel great. It's like, oh, well, you know what? That's actually great information for me. You know, like not just being like, oh no, my plan is ruined. It's like, it's great information. That tells me a lot.
Right.
Here's how we can like pivot from that. It's like, but then when you have a patient who's like, oh, I'm sure like this is going to hurt because I know this hurts my shoulder. Like, I know that there's something wrong with my shoulder. Like they just haven't done the right imaging. Like, do you kind of just, how do you approach that? Like, that's such a tricky conversation when somebody's so adamant about, oh, I know there's something wrong. Like,
right.
I know there's a tissue issue. They just haven't found it.
Sure. Would you be open to doing exercise on your other shoulder?
Oh.
Right? So if I'm trying to determine what their global system's response is, I don't need to target that arm or that leg even.
Yeah.
Right? I can target other tissues. I can use a more sort of semi-global approach.
Yeah.
And see, can we do that?
Yeah. No, that's a really interesting approach too. I mean, it kind of goes into like even the mirror therapy aspect.
Yeah.
You know, like
it's sort of a precursor to that.
Yeah. Can you actually tell us a little bit more, like with, especially with graded motor imagery and mirror therapy, like what does that look like, especially for the first session? Like because like explaining graded motor imagery in particular, right? Like you're imagining things, like you're imagining the action that you want to do. I feel like a lot of people will go, huh?
Yeah. I think it's not something you can just sort of on a whim start.
Right.
It requires a decent amount of education for them to understand, why are we doing this? Even? Like, why is this even a thing?
Right.
So that has to happen. Most patients, in my experience anyway, have been excited to do that because they have tried all these other things and been unsuccessful.
They need something.
And so they're looking for, like, this might help. They're game.
Let's do it.
Yeah. My experience mostly has been that people are excited for something novel to try. And remember that we're talking about all these things that are impacting input, but we're also going to talk about things that, impact descending inhibition. So it's not happening in isolation, right? So I've talked to them about sleep hygiene. I've talked to them about nutrition and pacing and all of these other down regulatory things. What is the impact of stress? What are the impact of these other drivers on their pain experiences? Yeah. Hopefully we've had some gains there. Okay, let's talk about what's happening on the input side of things, right? So our first session often is assessment-based, right? We're testing. Right? Can they do this? Can they do that? What does their laterality look like? What does their 2-point discrimination look like?
Right.
What does that sensory input look like?
Right.
And getting a sense of what happens with movement.
Yeah.
Patients love the mirror therapy, I have to say.
Really?
Oh my God. Well, because it feels safe, right?
That's true, yeah.
You're not moving the affected side, but we're tricking your brain into thinking you are.
Yeah.
So oftentimes you'll, let's say we're lifting the unaffected side and they can't see their affected side, but I can see it. And oftentimes both arms are going and they don't even realize it's happening.
Oh, that's such a funny thing. Like,
right. The brain's like, oh, okay. It tweaks it.
That's awesome.
Yeah, it's great. But it looks different for different patients. I had a patient once who had a multi-year long history of severe neck pain. She was incredibly disabled. She was unable to sit up. She was actually a scientist before she stopped working because of her neck pain. She was initially in a car accident 5 or 6 years before, maybe even longer before I saw her, but was bedbound most of the day. She couldn't have overhead lights on. She couldn't cook meals. She couldn't, the noise of she had 2 young sons, the noise of her children playing made her neck pain worse. She couldn't eat meals because her neck pain would be worse when she used silverware.
Yeah.
She would get pain down both arms, into both hands. And she was somebody where the idea, and I said, what's the biggest barrier? I just want to be able to sit down and have a meal with my kids. Okay. Why can't you do that? I couldn't sit and eat. Because you can't tolerate sitting? No, I can sit okay, but then my husband would have to feed me and I don't want him to feed me in front of the boys. Totally fair.
It's an independence factor.
Right, of course. Okay, why do you think you can't use a knife and fork? Well, anytime I even think about it, my neck pain gets worse.
That's big.
So I'm like, well, that's where we need to start then. We need to start with the thinking about it.
Yeah.
Is it knife and fork or is it anything? She goes, oh, I don't know. So for her first homework assignment was to take, I think it was People magazine. She said she had it home. Might have been US Weekly. I don't know which one. And go through and circle with a pen and paper. So she had to hold a pen to do it. Circle all the people eating in the magazine. Because, they have pictures of celebrities in restaurants. And so that was her homework assignment. So it meant she had to sit up, which I didn't tell her was part of the assignment. She had to look down, which was provocative for her, which I didn't tell her was part of the assignment.
Yeah.
And she had to circle people doing a task that she identified as problematic.
How did you come up with this? Or was this something that you researched, or was this something that were I have an idea?
No,
let's try
it was my idea. I knew that I needed to get her more exposure in a way that wasn't threatening. So I changed the context.
Yeah.
So her perspective was sitting at the dining room table with the boys with an overhead light on that are noisy. All of these things were going to be too much. So I set her up to be in a quiet space by herself.
Yeah.
Right, with her side lamp on so that she could do this task, which replicated physically a lot of the same things, but changed the stimulus.
It's almost like you're grading like the psychological factors too. It's like not just like, what, like we talk about like graded exposure to activity or like, gradually ramping up intensity.
It's exactly the same thing.
It's like you're doing that, but with like the psychological or the environmental factors.
Yeah.
You're really like, okay, let's take away the lights. Let's take away like the kids and like, let's take away like, the husband trying to feed you. Let's just focus on this. And then.
And I think we're quick to say those are psychological factors. They're not.
No.
Right? That light sensitivity is because her nervous system is upregulated.
Right.
That noise sensitivity is because her nervous system is upregulated.
Right.
Right? Without any descending mechanisms to help it.
That's a good point.
So it's not a psychological factor.
No.
It's the physiological response to stimulus that she should be able to inhibit, but can't.
Yeah.
So I got to retrain her nervous system. So physically, you could do all these things in a different environment. And we start with that. And so the next time she came in, I said, how was it? She goes, it was great. She brought the magazine with her to show me, which was great. So I'm like, okay, super. So now the next time, can you do that sitting at the table, like when the boys are at school? And she did that. And so we slowly increased the load over time. But you need to be creative about the pieces. And I wish I could tell you these are the things to do.
Right.
But they really have to be individualized based on that person. If I didn't ask those questions, if I didn't like deep dive into thing that was meaningful for her, those were missed opportunities for me.
Almost reminds me of like vestibular rehab with like I've seen where it's like, okay, like gradually, like, if it's, you get dizzy by looking side to side, particularly like post concussion or things like that, you're like gradually like exposing to yourself, like, okay, like watch your train like pass by distance.
Right.
And then look away when it gets too much.
Yeah.
Wait for symptoms to die down, then do that. It feels very similar, in that regard.
It's a lot of accommodation training, I think.
Yeah, exactly. I was like, oh, I like that. Like,
but the problem for most of these people is they live in a world where there's no accommodation.
Yeah, that's another like interesting, tricky like barrier.
There's noise in the world. There's lights in the world. Like she can't do all these things, and so she's going to the gym to try and exercise is literally so uncomfortable because she needs to be 57 steps back here and grading, and the world is saying you need to live in this space when she needs to be back here.
Yeah. Now I feel like that's like such a like cool intervention when they're like. We've been looking a lot about like, what is the role of PT, particularly when it gets to more like mental, like health sort of things.
Yep.
So like, I think that makes sense, especially from like a more like sensory perspective, like gradually exposing patients to that. But when you delve more into like the psychological, like facilitating like downward like inhibitors, like how do you know when the line is crossed between like your level of profession and then when you need to get to like, hey, like
when I need to reach out,
right? Like CARD, for example, if we talked about like at the BUPTC, you have that.
We're very lucky that we have people, clinicians who are knowledgeable about pain from a PT standpoint, but are psychologists that I can have a conversation saying, these are the things that I have tried. But I think there are psychological drivers that are limiting her. Can we work in collaboration on that? So it's not just any mental health provider can do that. It's a skill set. Just like not every PT might be appropriately trained to treat patients with persistent pain. Yeah. So I think one of the challenges out there in the world is finding good mental health providers that you can collaborate with. I think right now there's a mental health challenge crisis anyway in terms of just getting providers, but getting providers with that level of specific interest can be challenging. Yeah. So once you find one, it's like, you have a resource. It's like, thank you. Yeah. And I mean, I've worked with several individuals who have that background, and it's been very rewarding experience for me professionally, but also the patients have done very, very well, and they appreciate that level of collaboration. I think I'm probably better now than I was at the earlier stages in my career about identifying, okay, this is beyond the scope of what I feel like I have the skill set to manage, or they need more help, right? Their thoughts and beliefs about their pain experiences really seem to be driving things. And no matter how much I try and redirect that, I don't necessarily have the skill set for a full intervention on that. Those are the situations when I have phoned a friend, so to speak. Yeah. I think, and I think a lot is the language the patient uses about it. I mean, there are outcome measures you can use that'll help you determine somebody's level of kinesiophobia or fear avoidance, which can be helpful. Sure. But I've also had patients, use very scary language about like their frustration levels with being in pain and not willing to live like this. And those are so maybe adjacent conversations about, is this person safe? And when you need to make a different type of mental health phone call. But for the most part, individuals with persistent pain are just exhausted, feeling like they're constantly struggling without getting a lot of help or guidance. And they're constantly reaching out for help and not getting any sort of positive response in return.
Yeah. So like beyond also like we talked a lot about like the mental health like providers like clinical psychologists, but like do you also refer out to like other forms of like pain treatment? I mean, like I know some people like have really good results with acupuncture, for example, or I mean, I know there's like a lot of debate between the PT and the chiropractic world, but like I've seen a lot of times in both of my clinical experiences where you get like people going, "Oh, yes, I'm a chiropractor." It's like, "Oh, great, yes," and it's like, okay, and then like you kind of supplement that. Do you like what are some of like the more common providers that you've often like kind of either like worked with directly or contacted directly or referred patients out to try?
So mostly, I think my perspective mostly has been, what are the things that make you feel better, right? If going to your chiropractor makes you feel better, great. Don't not do that.
Right.
If getting a massage every other week makes you feel better, great. Don't not do that. If you feel like you've had success with acupuncture, wonderful. Like I'm all for facilitating anything that down regulates their nervous system. It's fine by me.
Right.
Ultimately, my goal is to have the person be able to manage their situation independently, but they need a relatively appropriate, healthy nervous system to do that.
Yeah.
So if they have strategies that have worked for them, fantastic. I tend not to recommend things sort of globally because each person is so unique.
Right.
So, things like, using like the Calm app or any of the sort of mindfulness apps.
Yep.
Those I have recommended for people.
Gotcha.
Because there's a free, you can try it for free. And if you love it, great. If you hate it, it's nothing except the 10 minutes of your time.
You've tried it.
Yeah. I mean, even things like, thermocare patches or heat modalities or, how to set up your room for sleep at night, like, avoiding screen time and making sure you're prepared for all of those things. I tend to start with that.
Yeah.
So it's things that the patient has some autonomous control over. I've had patients ask questions, I have a, relative who's done this in the past. Do you think that would work for me? And my first question usually is, do you think it would work for you?
It's like, what do you?
No, I think it's nonsense. I'm like, then I don't think it's going to work for you.
What's the point?
Right? Like, I don't know. I think I could try it. I'm like, well, if you're open to it, you should try it because if it helps you, that's great. And if it doesn't, what have we lost?
Yeah.
Right? I think I always have to consider the financial burden to think questions like that.
Yeah.
So I'm careful about recommending things that I don't feel like has strong evidence specifically to be able to support it.
Yeah.
And so many of these things are individualized. It can be tricky to have that.
Yeah. I know in some like cases too, like I remember my first clinical, there would be times when if like they were just struggling so much with like pain in general with everything that we're doing, they'd be like, just refer them to a pain specialist. To be fair, I was in a clinic where we didn't have a lot of time to treat because it was workers' comp. So like in terms of the amount of time like to do these kinds of interventions, we were very limited in that.
They might be better served in an environment like that.
Do you like, what sort of things should a patient expect going into like a pain specialist appointment? Like, is it like, how different is it from like our profession in that sense?
Yeah,
or do you know much about that?
I think it depends. The classic PT faculty answer. It depends.
Sorry, y'all. You can't escape.
No, it's everywhere. It depends. So if it is, so sometimes going to a pain clinic means you're going to see a physician and a physiatrist who specializes in injections. Sometimes it's like a work hardening approach, right? Which is just graded exposure therapy. It can mean different things. Sometimes it's a multimodal, excellent clinic where everybody has a good understanding of pain and they take a unified team approach. That's ideal. Like having resources that you can recommend patients to so that you're like, okay, I feel like I know enough about persistent pain to do a good job at this much, but then it's beyond my scope. Having somebody you can refer to, I think, is really helpful.
Absolutely.
And if I could make a plug for professional mentorship.
Oh, yeah.
As a young clinician, student, knowing somebody who you can reach out to, send an email to, I have a specific case, I'm not sure what to do, am I the best person for this? I think there is so conflicting levels of understanding out there, that if you're even asking that question, you're probably well positioned to at least help them more than they maybe have had otherwise. So
because you're curious.
Because you're curious, you're reaching out for help, you're trying to put those pieces together.
Yeah.
And you're invested in this person's well-being. And I think that's a really healthy approach to take. You know, you're not in charge of fixing them, but you're helping them on this process.
Right.
You're invested in moving that forward. So I think from a pain specialty standpoint, I think if you can have an understanding of what that means for that patient, I think it helps.
Yeah. And I think that, you know, that curiosity and that drive to learn more, like, you could learn as much as you want about the literature of like pain science, but like every person is different. And like I've had people like who they come into the clinic and they've had chronic pain, but then they have like another condition that could be contributing, but I don't know much about it. Like, funny enough, like I learned about, what was the condition I learned about? Like I learned about hiatal hernias for the first time in my last clinical. I was like, what? Like, patient, this is a person who had a car accident and she like, pretty like significant neck pain. It's pretty typical like whiplash associated like condition. And I was like, she's like, oh yeah, I have like a hiatal hernia too. Like, do you know much about that? I'm like,
I'm about to.
I'm gonna learn. It's like, I like quickly Googled it and I was like, all right, this is what I know about. Like, okay, I can guess like some things that I can help you with, like diaphragmatic breathing and doing like the splinted breathing just to help reduce that amount of pain if she's having any of that. And I was like, I'm gonna give you that for right now. I'm going to go talk to my clinical director and I'm going to see if he has any other thoughts.
Right.
And it was, but like, I feel like that's the kind of discourse we need in PT is to be like, hey, like this is a collaborative field. Right. This is not something where you should be like doing things in isolation and just for your own clinical practice. And
I think, you know, if you have a patient with persistent pain who has another injury, then that nervous system is getting nociceptive input.
100%.
So it's not just the loading from the nociplastic change, but also this new input from the nociceptive input. So it can be a lot to manage.
Yeah, there could be all three types, like all three.
Yeah, you could get lucky and have the trifecta.
Doesn't mean it's impossible to treat, though. It's just you have to make sure you're treating multiple different fronts.
Right, and just being mindful, like, what do I think the primary driver is for this pain experience? Yeah. Knowing that there might be multiple factors in play.
Yeah. Well, we're just about like wrapping up in terms of time. So I think main things I want to end on. What would be like it could be anywhere from like 3 to 5 top tips that you would give for especially new clinicians when they see a person with chronic pain come into their door? What is like your main like tips that you would give?
Listen more than you talk. Look for openings where you can plant a seed from an education standpoint. Be receptive to their input about how things are going. Share goal setting. What are the things that are important to them? And then the things that you think might be important to you to help them, you can work in there, but make sure that their goals are front and center. And then continue to learn.
I like it.
Get better over time. It takes a long time and it takes a lot of practice. And it changes all the time. What I do now is not what I did 5 years ago, and certainly not what I was doing 10 years ago when I thought I had finally figured out chronic pain. It's ongoing. And then my other last piece of advice was to give yourself some grace. It is challenging and it's okay to feel overwhelmed and it's okay to sometimes be frustrated and feel like I'm not quite sure what to do next and use your resources.
Ask for help.
Ask for help. Get mentorship.
True.
There you go.
Yeah.
Those are my top tips.
Great tips. You know, I want to also I was thinking of one thing, be a gardener. You know,
there you go.
You know,
be a botanist. We can be Mark Watney up in The Martian.
Let's get botany into PT. You know, but thank you so much again for being on the show.
Happy to talk to you.
This was so much fun. We hope that you all gain something from this. Stay tuned. We've got more episodes to come. But until then, have a great day, great night, and take care, everybody. We'll see you next time.